We are not trained that way. We are not trained to say, sometimes you as a clinician need to refer this person out, and you need to do it ethically and appropriately and do it as kindly and give that warm handoff if you can. But sometimes we need to do that, and it is okay.
Welcome to the Colleague Down the Hall podcast. This episode is sponsored by the Collab Oasis Clinical Consultation Groups. Hi, I'm Janine Wolf, and I'm your colleague down the hall. I have a passion for helping fellow therapists get the clinical and collegial support we all need to do this work. And wow, it just keeps getting harder every day. I'm the founder and facilitator of the Collab Oasis Clinical Consultation Groups. I have been a social worker for almost 30 years, and I own a successful solo online private practice. More of us than ever are practicing in solo or online practices, and we all need colleagues to process cases with, commiserate with on those really hard days, and also to celebrate our successes with. In this podcast, I'll bring you insights about trends and changes in our field and sit down with amazing therapists who are doing amazing work. We'll discuss fictionalized cases, ways to practice sustainably, and of course, there will be plenty of laughing. I love laughing with friends. I'm so glad to have you as one of my colleagues down the hall. Hello, everyone. You are listening to another episode of the Colleague Down the Hall podcast. I am your host, Janine Wolf, joined today by a group of colleagues to discuss a fictionalized case. Listen in as we look at various aspects of the case, along with treatment recommendations, areas of concern, and ways to look at those gray areas we often encounter in our field.
Today's a fictionalized case, but if this was a real case we were discussing, we would want to keep in mind confidentiality, and even if presenting the case, de-identifying the client as much as possible so that we can get that consultation in a protective way. Also, please keep in mind that license type and state of licensure may cause differences in the treatment approaches and ethical guidelines and legalities, and that's okay. So it might be that someone offers a suggestion that's state specific. And so again, they might say that this is specific to my state, they may not, but we all have to do our own due diligence in understanding what are the requirements of our state and licensure type and our ethics. And consultation is not supervision. So people are giving you suggestions and feedback, but you still are responsible for your case. So you do need to make sure that you're keeping that in mind as you're accepting the consultation from your colleagues. So the way I usually work is I am the facilitator of the groups, and I would love to do that today. So in order to do that, what I would like to do is request a volunteer to be the therapist in the case. And we did this last time and it worked beautifully. So what I will do is I will read the case, I will put it in the chat, and then if someone will volunteer to be the therapist, you get to take ownership of it. You get to, in your mind, decide how to answer questions people are asking. This client has now become your fictionalized client. So don't feel like you can't answer questions or come up with ideas, because I suspect that some of the dynamics of this case are ones that people have encountered anyway. So is there anyone who's brave enough to step up and be the volunteer therapist for us today? Marlo, are you volunteering? Oh, thank you, Marlo. That's wonderful. Thank you so much. Okay, so Marlo is going to be our therapist. Okay, John is a 35-year-old male who is being treated for anxiety. He has never been married. He works for himself and has quite a lot of flexibility in his schedule. Due to this, he often stays out late drinking and using substances, and this behavior has been increasing over the last year. John admits to experiencing blackouts on a regular basis and has also found himself in some high-risk situations. The therapist has been frustrated with his lack of progress with his treatment for his anxiety and attributes this to his substance use disorder. The therapist has told John he needs to seek treatment for his substance use disorder, but John refuses. The therapist is concerned about his safety and wants to discontinue treatment until he has dealt with his substance use disorder. So the therapist is wanting to know, can I discharge this client and what are the implications around doing so? Okay, so let's start with questions. Does anyone have any clarifying questions about the case? Let me just point out that this is not, if you don't have experience with substance use disorder, that's fine. That's really what the heart of this case is. This is a therapist who does not treat that. They initially took the client on because of their anxiety, which is something that's within their scope of practice. And now this other piece is sort of preventing them from making progress. And they're not the person to address that with them. So they're feeling kind of stuck.
Well, I definitely would like to have some input on my case. I have been working with John for quite some time, and my focus was strictly on the anxiety piece of it. And some of the things that I have been implementing was mindfulness activities, because he did report to me that he does enjoy meditation of some sort. However, he has not been engaging in it. I am not experienced with substance abuse, and I'm finding that he is often drinking. And so because of that, I feel that I do need to refer out, although he has already expressed to me that he feels uncomfortable with transferring to another therapist as we have developed a connection. And I'm just kind of lost, just trying to figure out what can I do.
And Marlo, are you concerned that if you continue seeing him and he doesn't get the treatment that he needs for the substance abuse, the long-term implications for his safety and that type of thing? I would imagine that that's kind of in your mind. It sounds like his behavior is escalating.
It is. It really is escalating, and it's interfering at this point with treatment. There was one time that he did call me while he was intoxicated, and I tried to assess the safety. I asked where he was, and he was at home, so he wasn't in the car or anything like that. But it's definitely raising a concern, and I want to make sure that my client is safe. I also want to make sure that the treatment is effective for him, and it just hasn't been, and I just feel that I should transfer him out.
Okay. Yes. And at this point, everyone feel free to unmute. It's just going to be conversational. We will just kind of jump in and have a conversation. So go ahead, Andrea.
Kind of a minor piece of what you're saying, but I'm curious, when he called you while he was intoxicated, do you know, was that intentional, kind of, I need this therapeutic support, or was it sort of almost a drunk dial type of situation where he didn't necessarily intentionally call you?
I feel like he intentionally called me because I feel that at this point I am one of his major connections, if that makes sense. I have been treating him for a while, and he just trusts me. And during the call, although he was intoxicated, he was stressed out about his career and just wanted to talk about it at that time, but he was just intoxicated. And I did explain that we can't discuss these things while he's intoxicated, because it's just an unethical thing, because you can't really receive when you are intoxicated. And so I strongly recommended, which I had an opening for the next day, that I see him for a session. And so that's how I handled it at the time, although I would love more suggestions on how maybe I could have handled it at that time.
Do you, is part of, because I know everybody sort of handles after hour calls differently, is that something that you would do for any patient in any situation, or was this sort of kind of an exception to your rule with talking to him outside of sessions?
Actually, I would say it was an exception, because I don't usually take out of, after hour calls. It was like 4:45 type of situation. Mm-hmm. And that's what happened. That's why I really answered the call. But I did not know at the time, obviously, that he was going to be intoxicated. I really thought that he was just calling me to maybe confirm an appointment or just update me on something. I really didn't. I just saw it and I answered it quickly.
I would just like to jump in and say, Marlo, that these types of cases are really hard, and I really feel for you. We do our very best to screen clients when they come into our practice to make sure they're in our scope of experience. Mm-hmm. But we also know that there are other things that we don't know. They either don't tell us, or things that come up. And so this is a situation that probably feels worrisome and stressful for you, because you're trying to do the right thing for him, but you also need to do the right thing. Some of the thinking is that if you keep seeing him and he keeps up this high risk behavior, he could die.
Yes.
If you quit seeing him, he may not seek treatment from someone else, but then he, you're also sort of setting the standard that this is the best treatment recommendation. It's really tricky.
Yeah. And I think that's, and I'll be honest, I know for a fact that I don't have all the qualifications and skills to address substance abuse, because I do not do that in my private practice. And when reading the biopsychosocial, even before he came with me, it wasn't indicated at all that there was any substance abuse. So now we're talking about 5 to 6 sessions in, and now an apparent that this is this issue. That's why I'm nervous. And I'll be honest, I don't want to hinder him further, that he already trusts me. And it's just, I just don't really know what to do.
I was wondering what kind of history you've done on him. What was his childhood like? What were the initial stressors that led to anxiety? What was some of that stuff?
Mm-hmm. Well, he came in because of career issues, but just to answer the question about his childhood, based on what he's told me already, he came from pretty much a stable middle-class family, no trauma, no abuse of, sexual, verbal, emotional, or anything like that. I believe that from what he tells me, his parents had high expectations of him career-wise. And so as he, he didn't go to college. He went to college for just a little bit, but he's an entrepreneur. Mm-hmm. And so I think, now at 35, he's thinking about wanting to do something different. So he's not going full-fledged into what he originally wanted to do. And that's what's bringing on all the anxiety, the expectation of his parents and things of that nature. But he did not disclose any alcohol or drug substance in the family. But of course, sometimes, clients don't tell you everything. So you just never know.
Mm-hmm.
Yeah.
Thank you.
Marla, I was wondering do you think because it wasn't on the intake and it wasn't information that you had, is this a new behavior? And also, has there been any kind of recent trauma or loss or anything in their life?
Not recently. He has not disclosed anything recently. However, because I didn't know about the substance abuse and it just came about, I feel that it was something that he did. And this is me really speculating. I do believe that it was a previous history. He just didn't disclose it to me because the symptoms, like how we've only been 5 sessions, I believe, if I'm not mistaken, maybe 6. And all this time, I'm seeing the behavior of him being intoxicated. He's told me verbally, after a few sessions, some incidents that had occurred of him blacking out and drinking and things of that nature. And that's what has caused me to believe that there was a longer history than he's leading to me to believe. But again, it was something I didn't know about. And that's why I'm kind of taken back by it.
So it sounds like really the question is, should you discontinue treatment for anxiety until John gets treatment for his substance abuse disorder? And,
mm-hmm. Mm-hmm. I feel so. I feel that he does, because I can't, although I said that he enjoys and he feels that, the mindfulness exercises are beneficial, and he even was engaged in things like that previously before therapy, it's not being effective because he's not being able to be mindful and be able to really engage in the breathing exercises, or really being engaged of being still with care and compassion while being intoxicated on a more frequent basis. So that modality is just not being effective at all. And so I recommend definitely that he does go I refer him to a substance abuse counselor and he receives treatment. But again, one of my issues is that he's kind of, I don't want to leave. I want to stay with you. I want to continue on. So that's where my And maybe that's, I don't know, maybe I have a little bit of countertransference going on. I'm not sure, but the main goal is for him to get the best treatment that he needs.
Okay. So is there anyone who feels that she should not refer out?
I do. I believe that clients continue to come to us because they are receiving benefit in some way. And I think, given what was just said, I would try to do the mindfulness in session, because I'm assuming he's showing up not intoxicated most of the time. And so maybe helping him do it and see the benefit of it over that 50 minutes or even half an hour, like even 15 minutes of it could really sink in and demonstrate to him that it is possible and to reduce the anxiety. And you never know, that might reduce his need to drink or use substances.
I never thought of that.
In person, in the session, because that is a strength. That's something you're comfortable doing. So engage in that way. And then in terms of referring out, I'm wondering about consulting with the person I would refer him to and say, what about doing a session with the three of us together, just so it's a super warm handoff, and see if you like that person, if you connect. There's no obligation, but maybe we could work in tandem instead of just launch, go do with somebody else. So there's no abandonment or any feelings in that direction. I don't know. I just think if you've already got that connection and that bond, I wouldn't break that. I just think that could be detrimental.
Yeah, thank you so much for that input. I never even thought about maybe consulting a substance abuse counselor together and doing kind of, well, not a handoff, but just to see if there's connection there and if he was comfortable. That is a really great suggestion, Lucinda. Thank you so much. I appreciate that.
Yeah.
And with the mindfulness and also conducting more of that mindfulness more so during the sessions, and sometimes we even taking up the whole session with doing it, because it does, specific mindfulness interventions do take 40 more minutes. So thank you for that.
Yeah. And keep in mind, that is 45 minutes of him not turning to a substance. Like, count every win for yourself and for the client, because you're doing good things, or he would not keep coming back. I do believe that.
Well, Lucinda, let me ask you this, and I'm not sure if you'll be able to answer the question. What do you feel about just my feeling of me not having the skills for the substance part of it?
I think that it's fine to hand off for the substance part, but any substance use disorder comes from emotion of some kind in my philosophy. And so by reducing his anxiety, that decreases a need to turn to other substances to alleviate that anxiety. And it can turn into more, definitely, if there's dependence that once he starts, but different types of therapy help in different ways. And so I would see that as so valuable.
Thank you for that, Lucinda. And Lori, it looks like both of you unmuted. So Risa, do you want to go first? Did you have something you wanted to?
Yeah, sure. I just like the way I agree with Lucinda. I was also thinking more in the framework of having gained the client's trust. It seems like, therapeutic relationship is having a good effect so far. And it seems like even though you feel, Marlo, that you may not have the expertise at the moment for his substance abuse issue. However, I also can see from your sharing how much this therapeutic relationship has been helpful for John. So I was wondering if, his drinking was attributed to, is one of his coping skills to cope with anxiety. And, so typically, removing alcohol can really be scary for John. And so if there are any skills that you can teach John in session, I think that would be really, really helpful, because typically I think when we remove sort of a coping skill or resource for someone, it might be helpful to replace it with something else so that the client does not feel kind of scared that they are left with nothing.
Thank you, Risa. That's helpful.
Yes.
And Lori, did you want to add something or ask this question?
Yeah, I just wanted to share that I think this case, and we can change sort of the dynamics to many cases, but I think there's sort of for me, I like to think of it, and maybe this will be helpful, it's sort of a parallel process whenever we take on a patient. There's what happens within us and how we formulate our belief about the patient. I think for the patient, there's that process of, will I be heard? Can I trust this person? And really, can I honestly show my true self? Can I be honest about what I'm doing? And how will it be received? And so your guess that he's been drinking far longer maybe suggests that I wonder if there's some shaming. And I would be very curious about prior therapeutic relationships. Maybe in the past, it would help me to know if he was rejected when he was honest about his use, and maybe there's a fear of that repetition. For me as a therapist, I think, and it's interesting listening to some of Hope's comments, because I am on the older end. I am in my 60s and I've been practicing for so long, and I'm at a place where I'm questioning a lot of where I am and what I want to continue doing. And one of the things that's helped me over the years is I've learned that I have to really make sure that I'm okay, and I can live with the fact that I'm bringing therapeutic value. And even if the patient isn't making the progress, that I feel like I am capable and competent in some way to sit in this misery. And if I'm really honest with myself, and I can give, we all probably could give some examples of moments where we know no matter what we do, no matter how much we consult, it's really out of our scope, then I have to be brave enough to own that and think of a safe way to transition with hopefully the minimal damage. If it's a situation where I feel like, well, I have the anxiety piece, he is connected to me, can I use that in a safe way to maybe do some harm reduction, and maybe talk with him about how, would it ever be helpful to talk about, what he wants from you? So I think I would switch to, would it be helpful to you to find out what keeps him coming back to you? Why did he choose you? That's always an interesting question. What about you has been helpful for him? And then to talk about what you do know, where you shine, and that's the anxiety. And what you know is you can help people with anxiety, and there's lots of different ways to do it. And maybe for him, alcohol is one of the ways he managed his anxiety. But I think his call to you drunk maybe was intentional. He wants you to know how much he's maybe suffering, and maybe to talk about how does he feel about the fact that he called you? How does he feel now knowing that he has this huge problem and you're worrying about him? Maybe that's how he feels cared about. So I think what I would do before I made a decision is try to really assess what he sees as the benefit to help you feel more comfortable, and what he wants or doesn't want to do about the alcohol. Maybe he wants to make a change, but his anxiety is, he's afraid of how he will function without it. So that's where I think if I, as a therapist, said, I want to work with this, I feel like there's enough to keep going, then maybe I would consider, do I need to maybe present having worked with someone alongside of me? Do I need to learn about things like motivational interviewing and readiness for change, and find out where he's really at?
Yes.
So sometimes when I'm stuck, I even might put the dilemma out to the patient. I don't want to refer you out, but I don't want to not help you. And share the problem. And sometimes I have found that as helpful. So just some thoughts from older therapists.
No, that is wonderful. I think that's really fantastic. That is definitely something I could use. And you even mentioned in the wand reminds me of reality therapy and making that list out and choosing. So you gave me a lot to think about and to be able to incorporate that. So, I mean, yeah, all of this is really, really helping me a lot.
Good. And I guess the last final thing I would say is one of the things I wish somebody had told me 30 years ago was, if in your heart you truly, truly feel like you cannot tolerate or feel safe or feel comfortable working with a patient, you have to honor it. I've made that mistake of not listening to my gut. And so that would be sort of the last piece that I would share, is we have to also as much as we want to honor and not abandon patients, we have to trust our own needs as well.
Lori, thank you so much for saying that. That's something that I have been, people that follow me know I've been preaching this for a while.
Okay.
We have to put ourselves into the equation. And I'm so glad you brought that up, because we are not trained that way. We are not trained to say, sometimes you as a clinician need to refer this person out, and you need to do it ethically and appropriately and do it as kindly and give that warm handoff if you can. But sometimes we need to do that, and it is okay. So thank you so much for saying that, because again, no one tells us that.
No. I hope I did okay with the story, though. I was trying to make things up as I go.
Yeah, you did a wonderful job. Yes, Marla, that was wonderful. Thank you so much. And Eleanor, did you want to say something?
I just really quickly wanted to point out, you mentioned something about his parents and how they had high expectations. And sometimes we can get caught in this shame cycle, shame loop. And one of the things that we do to recover is those things that are very unhealthy for us, the drinking or whatever that is, and maybe exploring some things that trigger a shame cycle for him.
Absolutely. Yeah.
That's
and
great.
Andrea, did you have something to add?
Just really quickly going off of what Lori was saying, I was wondering, as far as harm reduction, he doesn't want to see someone specifically for substance use, but is he willing to kind of try to cut back, or does he see it as a problem, and kind of exploring that piece of it with him, because maybe he's not ready to go so far as specific treatment for it, but he's willing to find ways to cut back, or he's willing to look at some of the risks and change some of those behaviors. So that might be another piece to incorporate with him as well.
Thank you, Andrea. Okay, well, I'm going to start summarizing a little bit because we are reaching the hour. I appreciate.
I think somebody had another question, though.
Is somebody? Who?
I think Tia had another question. I didn't mean to interrupt you or anything.
No, please. No, I'm glad you did. Sorry, Tia. I'm so sorry.
No worries. I was just going to add a little bit, but honestly, it won't change the dynamic. I was just going to say, we really do need to honor that we're clinicians of our own expertise and we cannot know everything. And I don't think we should. And so recognizing that and being able to do consultation or referring out on all of those different levels of appropriateness. At the same time, when we look at something like addiction, drinking, that is similar to many other behaviors that you might be seeing, such as self-harm. This is being used to escape, to not feel, to whatever it is, to not have that. So there are other things that might look similar that you already have experience with, where you can kind of take some of those tools and skills to help your client increase their desire for change, and that's the thing where I think could be really helpful. But I 100% encourage, when you're uncomfortable, to speak that to a client, because they deserve the best care. And if we're just kind of hanging on because we have a solid relationship, I do believe relationship is, I think research shows it's like 60% for whatever is a high percentage of the change in therapy, but it's not in itself enough. They need to have the skills we can't just treat anxiety by being nice, right? So I think that while a relationship is critical, if you don't have the skills to help him acknowledge and work through the drinking and the criticalness of it, I think that's important to send out and to be okay with that. Because if you go to a doctor and they say, this is all you need,
take this and you'll be fine. You're trusting your doctor. They're the expert, right? They're the professional. Same with this client. If you say, keep coming to me, we're going to be okay. They're not going to say, I think I need something more. Not many people do. So being able to take that stance in our professional seat as well by saying, this is not enough.
Yeah. That's great points, Tia. Wow. So Marlo, you did a fabulous job. Thank you so much for stepping up. You were on the spot coming up with things that can be tricky to do, but you did a wonderful job. Thank you so much. I would just like to point out that what we heard today were a variety of responses and thoughts and perspectives. And that's good because we each practice differently. We each have different ways that we relate to clients. And the unique thing about a group consultation is now Marlo, if this were really her client, would get to take all this information, process all of it, and figure out, okay, what is the best thing for my client as well as myself? You know, because it does encompass both of those, both yourself and the client and their safety, the safety of your license, your own emotional and mental well-being in managing cases, and all of those things are important. So the last thing I would say that the next step would be to make sure you do really great documentation on this. I know that I was trained to get consultation. It's a best practice, but I wasn't really trained about how to do that. And so what you want to make sure you're doing is making a note, the date, your information about the client, who you consulted with, what were the recommendations, what were the discussion points, what were the different aspects of feedback that you got. Then if you're going to change your treatment or make any type of changes or recommendations to your client, or if you're going to refer out, document that as well, sign it and date it and put it in the chart. Because if it's not in the chart, it doesn't count, it didn't happen. And if someone were to investigate your management of this case, they're going to say, how would your peers have handled this same case? And now you're going to have demonstrated, I did my due diligence. I talked to multiple peers, and then I use my professional experience and intuition to decide the best way to go with this client. So that's just the final piece that I always want to make sure that we're all doing, because like I said, I think most of us get consultation when we need it, but I don't think a lot of us are trained in really, I mean, I in the past would put notes like consulted with colleague. Yeah, that means nothing. If I'm in court, they're going to be like, okay, that means nothing. So I just want to make sure that we all remember that piece as well. So thank you again, Marlo. Thank you everyone for sharing your perspectives and your expertise. It's so interesting to hear the variety of perspectives and the different unique lenses everyone brings. So thank you everyone so much for coming.
For everyone listening, there are new episodes of the Colleague Down the Hall podcast released every Thursday on all major platforms. Please remember, our work is hard, but it doesn't have to be lonely. Thank you so much for listening to the Colleague Down the Hall podcast. For show notes, links, and downloads, head over to colleaguedownthehall.com, where you'll be able to learn more about getting the clinical support you need and resources to help you work in a supported, sustainable way. If you've enjoyed this episode, please share with your therapy friends and colleagues. Subscribe to the podcast, and if you loved this episode, please leave a review.